Welcome to Target PEBC Prep. My name is Mohit Koladia and today we'll be talking about anticholinergic drugs. So let's start with the anticholinergic agents. So again, it is very important from PEBC point of view and for your base in pharmacology, okay? Anticholinergic drugs. So what are anticholinergic drugs? So these are basically antagonists, okay? These are antagonists to cholinergic receptors. So what do I mean by antagonist to cholinergic receptor? Is that it binds to receptors but no intrinsic activity. By this, it has a property of antagonist that it has affinity but no efficacy. Okay, so all antagonists have the property of binding to the receptor, but there is no intrinsic activities. Okay, so there is no pharmacological response. Okay, so now these drugs can be studied as two divisions. So let's understand what are those two divisions. Okay, all right. So these anticholinergic drugs can be studied as anti-muscarinic agents and anti-nicotinic drugs. Okay, so anti-muscarinic agents, they basically block the muscarinic receptors, and this anti-nicotinic drugs, they block the nicotinic ion channels. Now this anti-muscarinic agents can be further divided into two types. One is the non-selective, that is they are not selective towards any of the muscarinic receptors. Like you have five types of muscarinic receptor, right? M1, M2, M3, M4 and M5. So these are not selective to any of this receptor. This binds to all general receptors, muscarinic receptors, and it gives effects by inhibition of all these receptors. So the prototypes here that we need to remember could be atropine and scopolamine. Just remember, these are very important drugs. And the selective agents are basically M1 selective, that is pyrenzapine, M3 receptor antagonist, example is darifenacin. So I'm just giving example of important drugs right now, but we'll come across other drugs. Now this anti-nicotinic drugs could be further divided into ganglionic blockers and neuromuscular blockers. Okay, neuromuscular blocking agents. So neuromuscular blockers. So I'll explain you right now what are these ganglionic blockers and neuromuscular blockers. It is important to know. Okay, so let's study like a general human body structure. Okay, this is central nervous system. You have muscarinic receptors, and then you have nerves here in the spinal cord. There are neuromuscular innervation. So say this is parasympathetic system, okay? And say for example, this is your heart. This is parasympathetic nerve fiber. Innervation, okay? And you have a shorter ones, that is, this is parasympathetic. And you have your organ here, okay? It could be anything, maybe say liver or anything. And this is sympathetic. Understand this nicely because it makes your understanding easier further. And this is skeletal. So this is your skeletal muscles. Okay, so the terms you need to understand. Now in parasympathetic innervation, always in the parasympathetic and the sympathetic innervation, this in the ganglionic region, your neurotransmission always occurs through ACH. So ACH is the neurotransmitter responsible for the neurotransmission in the preganglionic neurons, okay? But when it's parasympathetic system, you always have ACH in the postganglionic regions or the neuroeffector junctions. So this is called neuroeffector because you have neuron and you have effector organ. So this region is called neuroeffector junctions, okay? So this how it works is the basically you release ACH from here, you have nicotinic ion channels, here, and also you have nicotinic ion channels here, alright. So they also have a nicotinic ion channel. So you have nicotinic ion channels on the ganglionic regions. The neuroeffector sides, you have muscarinic receptors or you have nicotinic ion channels. On this sympathetic innervation, you have ACH in the preganglionic region, and in the neuroeffector region you always have neurotransmission occurring through norepinephrine, except in sweat glands, okay? Exception is sweat glands where you have ACH as the neurotransmission, okay? Even though it's in sympathetic innervation, it has ACH in the neuroeffector region of sweat glands. Just remember this. And in this you only have one junction, and that's called neuromuscular because this is muscle and this is neuron. So this is known as neuromuscular junction. Okay, so you have nicotinic ion channels here and you have ACH released here. So ACH plays role in parasympathetic innervation and neuromuscular junction, as well as in the preganglionic neurotransmission in sympathetic innervation. So this is important to remember. So where does your ganglionic blocker work? Now this is the ganglion region, okay? So your ganglionic blockers work here, okay? Ganglionic blockers. Right? And your neuromuscular blockers will work here. So your neuromuscular blockers work here, okay? And your anti-muscarinic drugs will work here as well as here, it will work here, right? So your anti-muscarinic, because you have muscarinic receptors here, they will mostly work on neuroeffector junctions. So that will be muscarinic, anti-muscarinic drugs here. Okay, anti-muscarinic drugs work here, ganglionic blockers work here, neuromuscular blockers work here. Just understand this nicely. Okay, so now let's start with the atropine, the prototype drug. It is an plant derived alkaloid. Okay, obtained from Atropa belladonna. Now the important points to remember: when you give it systemically, it works for up to 4 hours, but in the eyes, conjunctival sac, when you are giving into eyes, it works for 3 to days, it stays there for 2 to 3 days. Okay, so remember this. Now let's consider the different effects of atropine from starting off head. Okay, just imagine a human body. Let's start from the eyes first. So what are the effects of atropine on eyes? Okay, in eyes you have sphincter muscles in your eye. They have M3 receptors. Okay, so when you give this atropine, it's blocking M3 receptor in the eyes and it produces mydriasis in the eyes. Okay, now in eyes it also produces blurring vision. And this is due to paralysis of ciliary muscle. In the eye. Okay, now this atropine is used to produce pupillary dilation, but always make sure when you are using atropine or any antimuscarinic agents, never give to patients with narrow angle glaucoma. Okay, because you will dangerously increase the intraocular pressure, and that may lead to permanent blindness. So please do not. Now, in what conditions atropine is used in eyes? So it is usually used for checking refractive errors. Okay, so a good ophthalmologist will always use this for while checking for refractive errors. You use this, and also for normal checking of retinal functions or doing retinoscopy, they use atropine. Okay, to produce it is used to produce paralysis of ciliary muscle. Okay, now the main point, you don't use atropine nowadays because atropine, as I told, it stays for 2 to 3 days, right? So mostly the drugs used are home atropine, cyclopentolate and tropicamide. So this is longer duration and this is shorter. So the shortest one is tropicamide. So most doctors will use tropicamide because it gives temporary action only. Okay, it's a short duration of action. Now after eyes, let's discuss about the secretions. Okay, so in secretions you need to know it decreases the secretion of salivary glands. Salivary secretion reduce, right? So it leads to xerostomia. Decreases the nasal and respiratory secretions. Okay, it also decreases sweating. Condition is known as anhidrosis. Okay, now because of this decreased sweating, it also leads to increased body temperature. And also decreases the ophthalmic secretions. So that is called xerophthalmia. Alright, understand this or remember. And it also causes general cutaneous dilation. Condition is also known as atropine flush. So these are the general effects. Okay, these are general effects caused by atropine. All right. Now after secretion, let's discuss what it does in respiratory system. So in respiratory system, it basically causes bronchodilation. Easy to understand because your parasympathetic activation was causing bronchoconstriction. So by blocking the parasympathetic activity, you are causing bronchodilation. So you use in asthma, right? Exactly not atropine is used, but they use ipratropium. Ipratropium is used in COPD. Okay, it is a related compound to atropine. All right. Now in GIT, just try to remember the cholinergic system was doing. It was increasing the motility, right, of gastrointestinal tract. So this will decrease GI motility, right? So these are antispasmodic drugs. Okay, it also decreases GI acid secretion. The main drug used here is pyranzapine. It is an M1 antagonist, M1 receptor antagonist, which decreases the GI acid secretion. So used in peptic ulcers, right? Then urinary system, M3 receptors are present. Okay, so you use basically darifenacin, relaxes the detrusor muscle. used in urinary incontinence. Okay, just remember this drug, M3 receptor antagonist is darifenacin. Okay, now the important one that you have to know very nicely, cardiovascular system. Okay, how the effects of atropine works on cardiovascular system. All right, so let's jump into cardiovascular system. Okay, CVS. What are the effects of atropine on CVS? Now let me draw a brief heart diagram. Okay, so it's not the best but still okay to understand. Four chambers of the heart. You have SA node, you have AV, and you have all that fibers, right? Purkinje's, bundle of Hayes and all. But just remember for now SA node and AV node. And this is your neuroeffector junction. ACH is released, right? Now what happens is on the neuroeffector innervation of heart, M1 receptor is here. It's a presynaptic M1 receptors, okay, and or prejunctional, and this is postjunctional. You have M2 receptors. M2 receptors, and this is M1. So normally what happens is this acetylcholine comes and binds to M2 receptor, and M2 receptor works, so ACH binds to M2 receptor, and M2 receptor works through GI inhibition mechanism through G protein couple, right? So what they do is they usually decreases the velocity and velocity of the current, right? So they decrease the heart rate, right? So this is how the normal mechanism is, okay? And in the normal heart you also have this M1 receptor. So what M1 receptor does is, M1 is auto-inhibitory receptors, auto-inhibitory. So it works through a feedback mechanism. So whenever the ACH level in this region goes high, it binds to M1 receptor, which inhibits further ACH release from the terminal, right? So you have less ACH available and your heart velocity is maintained, okay? ACH inhibits M2 mediated activity, right? So you have your normal heart rate maintained, okay? So now understand atropine in low dose. When you are giving atropine, it works by binding to prejunctional M1 receptors, okay? So you are inhibiting the M1 receptor. So what would happen is, in the junctional area there will be increased ACH accumulation, and that increased ACH accumulation will be working through M2 receptors, causing decreased heart rate or bradycardia, right? by inhibiting the SA node and AV node. Okay, so you are causing bradycardia. Now when you give moderate dose of atropine, it blocks M2 receptor. So it preferentially works on M2 receptor of the heart. So that is the, so this was pre-junctional and that is post-junctional, right? So when you are blocking M2 receptor, what you are doing is you are increasing, or you are, so what happens is when you are blocking M2 receptors, the SA node is basically escaping the parasympathetic activity, right, or ACH mediated activity. So here what would happen, because your heart will have both ACH mediated activity as well as the sympathetic activity. So because you are blocking M2 receptors, your sympathetic activity will increase, and that sympathetic activation will lead to increased SA node and AV node activity, right? So that is tachycardia. So understand this nicely. In low doses, you are binding to M1 receptor and you are inhibiting the release of, you are inhibiting M1 receptor and you are increasing the ACH accumulation in the junctional area, and that is binding to M2 receptor, and that leads to further inhibition of SA node and AV node that causes bradycardia. But in high doses, you are preferentially blocking the M2 receptor mediated bradycardic action. So basically the sympathetic stimulation is working dominantly and that causes tachycardia. Okay. Now what would happen if you are giving it in toxic dose? Okay, so that was low and moderate dose, right? So now let's discuss briefly, just a brief. So in toxic dose, very high dose, that's dangerously toxic, it will block M3 receptors on endothelial cells. So if you remember from parasympathetic system, your endothelial cells have M3 receptors, and normally endothelial, like ACH binding on endothelial cells would cause nitric oxide release, right? But when you have toxic dose of atropine, what you are doing is you are blocking M3 receptors and you are inhibiting the NO mediated release, right? So when you are having toxic dose, it will cause severe increased. Okay, so let's study with the example. So in conditions like when this atropine could be useful in sinus bradycardia, when your heart rate or SA node activity is very less, and when you have an AV node block, atropine could be helpful, right? Because it could cause tachycardia at moderate doses. Okay, now atropine has a one very important use in pre-operative conditions and the post-operative conditions. I think that is important to understand. So there are reasons why it's given in pre-operative care. Okay, pre-operatively atropine is given because it decreases the salivary and respiratory secretions. Okay, the another reason is it decreases the vagal reflexes. So, because while you are opening the body in operation or surgical procedure, you want to avoid complications by decreasing the salivary or respiratory secretions, because when you give anesthetic agents like ether, the bronchioles get irritated and they release a lot of secretions which might cause pneumonia and further complications post-operatively. So you want to take care by giving atropine pre-operatively. Now when you open any visceral organs or visceral cavity or peritoneum, in that case when you open this, the body activates the vagal reflexes which might cause bradycardia. So you want to avoid those conditions, like if you want to inhibit those vagal reflexes, you use atropine. And the third is the related to the post-operative care. Okay, so understand this. Okay, so what happens after you, so after the operation, you want to block the unwanted parasympathetic activity, because during operation we give muscle relaxants like tubocuranin, right? So when you give those, we have to remove these muscle relaxants after the operation. So what we do is we give neostigmine, right? When we give neostigmine, it will competitively remove muscle relaxants, right? Because how it works is, okay, say your muscle relaxant is here, you have ACH released and you have this enzyme acetylcholine esterase. So you are basically giving neostigmine to inhibit acetylcholine esterase, which will increase the level of ACH, which removes tubocurarin or other muscle relaxants competitively. Okay, so what happens in this case, you can remove the muscle relaxants here, but this neostigmine will also inhibit the acetylcholine esterase at other organs where there will be an increased ACH release, right? So that increased ACH release will give negative effects on other organs like heart, right? So to avoid these negative effects, we want to prevent the ACH binding to the organ. So what we will do is we will just give atropine, and this will inhibit other negative effects. Okay, it will bind to the muscarinic receptors and block them, so that further ACH release due to the neostigmine won't affect the organs like heart or liver, right? All right, now it could also be used, very important to know, atropine could also be used as antidote. Okay, it could be used as antidote in three conditions mainly. So one is the organophosphate poisoning, right? In organophosphate poisoning, why does it work as antidote? Because you have inhibition of acetylcholine esterase, which leads to increased acetylcholine throughout the body. So atropine blocks this effects. So you use it in organophosphate poisoning. You also use it in the physostigmine overdose. Okay, same way it inhibits the increased ACH action, because physostigmine will increase the acetylcholine levels by inhibiting the acetylcholine esterase, and also it is used in cholinergic crisis. So basically you have all that effect of dumbbells, right? We studied in last video. So this cholinergic crisis causes dumbbell effect. You give atropine, it inhibits this. So it is anti-dumbbell. Okay. Now on CNS, atropine has very complicated actions. So just remember for your sake, in CNS, atropine in CNS it will cause delirium, it causes hallucination, and it causes convulsions leading to coma and death. So atropine overdose could cause this. So just remember, it first initially stimulates and then inhibits CNS. Okay, good enough. Now let's just discuss briefly the related drugs. Okay, so the related drug is scopolamine. Okay, the points important to remember is it is able to cross BBB, blood-brain barrier. Okay, so it has got CNS actions, and it is specifically used for motion sickness. And in CNS it basically inhibits. Okay, it inhibits the CNS activity. It doesn't work like atropine. Atropine has first stimulates and then inhibits, but this directly inhibits the CNS. So it is used in motion sickness, very important, and it is used as preventive, so give before traveling. Okay, and this is given with morphine as anesthetic combo in operation combo. Okay, and it also causes enterogate amnesia, temporary forgetting. Okay, another important drug is ipratropium. It is quaternary ammonium, so cannot cross BBB and hence no CNS activity. Okay, only used in COPD. And the other related drug which have replaced it is tiotropium, because it has longer duration of action. Tiotropium. Okay, not ipratropium. Now they use tiotropium mostly. Okay, now in Parkinson's disease, initially dopamine, so you have acetylcholine and you have dopamine. balance in your normal brain. But in Parkinson's disease, the balance goes like this. Dopamine level decreases and acetylcholine level increases. Okay, so you have choline level increased. So what you want to do is you want to reduce the cholinergic activity, right? So to reduce, because this increased cholinergic activity, it is giving symptoms of tremors. So what you do is you use anticholinergic drug along with levodopa, L-dopa plus adjunct drugs, anticholinergic. So these drugs are mainly benzatropine, then you have trihexylphenidine, okay, and then you have piperidine. Just remember the drugs: benzatropine, trihexyphenidyl, and piperidine. You give along with L-dopa in Parkinson to reduce the anticholinergic, to reduce the cholinergic activity. That is, you get rid of this tremors. Okay. Then for ophthalmic purpose, where do you use this? Ophthalmic uses tropicamide is mainly used for refractive error correction and all that, because of shortest acting, right? It is shortest acting. Cyclopentolate, you have homatropine, it is longer, medium. Okay, tropicamide is the drug of choice, but make sure no narrow angle glaucoma. Okay, you cannot use this, is contraindicated. Because you will further decrease the angle and dangerously intraocular pressure will increase. In GIT, pyrenzapine decrease the acid secretion. Then for you have glycopyrrolate, dicyclomine, methscopolamine. These are to decrease GI motility. It is also called as antispasmodic drugs. Okay. Then in urinary system, need to remember darifenacin, tolterodine, and oxybutinin. All right, used in urinary incontinence, right, to relax the urinary muscles, urinary bladder muscles. Okay. All right, and that finishes the chapter for what do you call, this was anticholinergic, but we are only finishing the antimuscarinic now. I'll come up with the next video which discusses the anti-nicotinic drugs, that includes ganglionic blockers and neuromuscular blockers. Okay. Thank you very much for watching and listening to my video. come back again. Please like or subscribe to my channel.